Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about menopause. So what we wanted to know about menopause, the definition, the types of menopause, the hormonal changes that happen, morphological changes during menopause, menopausal syndrome or what's called symptoms of menopause, the health hazards during this period of life, the diagnosis and treatment. So please look to this picture. This is the stages of female life starting from infantile period, childhood, pubertal age and adolescent, childbearing age, then menopausal age and post-menopausal age. There is many physiological and morphological changes occur during the female life from infantile age to postmenopausal age due to the hypothalamo-pituitary ovarian axis and due to sex hormone steroids produced from the ovaries like estrogen and progesterone, and the change from childhood to pubertal age start when the hypothalamus, which secrete gonadotrophic releasing hormone in a continuous manner, change its rhythm and change its secretions in the form of pulsatile manner. And this pulsatile manner in pubertal age will stimulate the pituitary to release FSH and LH in certain manner that stimulate the ovarian follicle to produce estrogen and progesterone while it's growing to reach maturity. Okay, so the growing follicle produce estrogen and progesterone will do many physiological and morphological changes and change this child from being just a child to another adolescent girl with secondary sex characters and the development of menarche, which is the first menstrual cycle in her life. Then continuation of the menstrual cycle all over the years in a childbearing age, which is the best time for pregnancy and delivery. Okay, and the lady goes through the perimenopausal age and menopausal age and postmenopausal age. Why it happens? Because there is depletion of the ovarian follicles in the ovary, and so the estrogen produced and the progesterone produced from the ovary decreased, and the inhibin hormone also decreased. So the hypothalamus and pituitary try to produce more FSH and LH to stimulate the ovary, but there is no more follicle. So this depletion of hormone of estrogen and progesterone due to depression or inactivity of the ovarian follicles leads to menopausal symptoms and menopausal changes and the morphological changes that we will discuss today in this lecture. So this lecture around this era of age of perimenopause and postmenopause age. Let's start. So what is the menopause? Menopause, as you see in the picture, cessation of menstruation for 12 months above the age of 45 years. This cessation of menstruation associated with inactivity of ovarian follicle and reduction in the production of sex hormones. So what is the climacteric or menopausal transition? This is the period between, if we said this is the menopause age, this is the climacteric means the transition between the childbearing age before this and the postmenopausal age before this. So this area is called climacteric. And during this period, the cycles becomes irregular, ovulation become irregular until cessation of menstruation completely for 12 months. This is the climacteric or menopausal transition. You should know that the age of menopause range between 45 to 55, okay? And we have different types of menopause: natural, premature, and induced one. Okay, what is the natural menopause? Natural menopause, as we said before, cessation of menstruation for 12 months during the age of menopause, which range between 45 to 55, with the mean age of 51 years. Okay, due to depletion of the ovarian follicles and decreased steroid sex hormones secretions. Okay, okay. So what is the premature menopause? If this menopause occurs at younger age, before the age of 40 years, this is called premature menopause, which may occur idiopathic or constitutional or familiar or due to genetic reason or environmental causes or autoimmune disease or immunological factors. While the third type of it, which is the induced menopause, means the menopause now occurred because of I removed the post ovaries, as in bilateral oophorectomy during surgery, okay, or I I induced damage for the ovaries by during giving chemotherapy for malignant cases with cancers, okay. So chemotherapy can cause damage to the ovaries, so inducing menopause. Also, radiotherapy for treating malignancy may cause menopause, and this is called induced menopause because radiotherapy causing damage to the ovary and ovarian follicles. So this is called induced menopause. So before starting menopause, the lady will find that the menstruations become irregular. There may be oligomenorrhea, hypomenorrhea, or sometimes heavy menstrual period after cessation of menstruation for or 2 or 3 months. So this is considered the start of occurrence of menopause. Okay, so what is the hormonal changes with menopause? Please look to this picture. What is happening is that there is depletion of the ovarian follicle, so there is decrease in estradiol. This decrease in estradiol secretion will act on the pituitary and the hypothalamus. So suppose normally there is increase in secretion of estradiol, which will have a negative feedback on the pituitary and the hypothalamus, okay? Okay, to regulate the release of FSH and LH. But here there is no more estradiol. There is decrease in estradiol. So FSH and LH is excreted more and more, okay? Because the hypothalamus and the pituitary is released from negative feedback mechanism. Also, inhibin, which is released from granulosa cells in the follicles in the ovary, is decreased due to depletion of the ovarian follicle. And this inhibin hormone suppresses the release of FSH and LH. So decreased inhibin will lead to increase in FSH and LH. So what is the result now? I have decreased estradiol, decreased inhibin, but at the same moment there is increase in FSH, LH, increase in norepinephrine, increase in dopamine, increase in prostaglandin. And all these are responsible for the hot flashes, symptoms, vasomotor symptoms, insomnia, and depression. Okay, what is the result of decreased estradiol secretion from the ovary? It will affect the bone, it will affect the blood vessels, it will affect the genital tract and the breast. In bone, it may cause osteopenia or osteoporosis. In cardiovascular system, may cause atherosclerosis. In genital tract and the breast, may cause atrophy because of deficiency of estradiol or estrogen. Okay, so this is the main problem here, is the decrease of estradiol. Okay, This is another picture showing you the estrogen and the progesterone curve and the FSH and LH curve. You will notice that there is decrease in estrogen and the progesterone down in the age of menopause, a while increase FSH and LH. Okay, let us complete the somatic changes. The breast, as you see, will atrophy, becomes more pendulous, except in obese women, the fat content on the breast may compensate for the atrophy of the glandular tissue. But in some people, the atrophy of glandular tissue will be reflected on atrophied breast and become pendulous one. Okay? Okay. There is hirsutism in the upper lip and the chin, as you see in the picture. There is increase in body fat in the abdominal area, as in this picture. Normally, in the childbearing age, the increase in body fat below the waist, while in the postmenopause above the waist. That's why they call it during childbearing age, the shape of the lady is pear shaped, while the obesity here, because of accumulation of the abdomen in postmenopause in the abdominal area above the waist, make her apple shape. Okay, what about the skeletal system? There is loss of the calcium from bones due to osteoclastic activity, and it's considered about in a rate of 1% per year. So osteoporosis may happen in some women in postmenopause age, especially the vertebra, the distal radius, and the neck of the femur. What about the cardiovascular system? There is increase in cholesterol, LDL, and decrease in HDL. There is liability for hypertension and ischemic heart disease in such age. What about the genitourinary changes? Please look this picture. There is atrophy or thinning of the labia majora. The pubic hair is little, and there is narrow introitus, which may cause dyspareunia, and there is atrophic vaginitis sometimes. And you can see here the thickness of the vagina in a childbearing age. This is the difference. This is the thick in childbearing age, and this is atrophied and thin in during menopause. Okay. Also, there is decrease in vaginal acidity during menopause. Vaginal phronesis becomes contracted and flushed, and with the cervix, and becomes a cone shape. The cervix, as you see in the picture, cervix, this is during the perimenopause, still there is some cycle, menstrual cycle, still some sickness in the endometrium, but in this picture, the endometrium is thin, atrophied in postmenopause, okay? The uterine muscle decrease in the muscle, and the size of the uterus decrease, and the ratio between the cervix and the uterus nearly 1 to 1. There is cervical stenosis. The cervix atrophied and becomes flushed with the vagina. And if there is fibromyoma or leiomyoma, it may shrink during the postmenopausal age due to deficient estrogen. What about the fallopian tubes? It becomes short, becomes thick, with loss of plica, epithelial plica. Ovaries shrunk, becomes small and wrinkled and more fibrous. Ligaments and the pelvic fascia atrophied, and this is a predisposing factor for prolapse in such age of postmenopause. What about the urinary tract? In the picture here, this is the trigone, the epithelium of the trigone, and this is the epithelium of the urethra. The epithelium becomes thin, okay? And the connective tissue and the elastic tissue becomes thinner, and the muscle lost its tone. That's why the postmenopausal lady complain of stress incontinence and urge incontinence, and the frequency of micturition, and the liable for urinary tract infection. So what about the menopausal syndrome or menopausal symptoms? Okay, of course, it doesn't occur in all ladies. Maybe 50% of women may develop these symptoms. The duration and the severity vary between the women, may occur before, during, or after cessation of menses, so in the perimenopause age and postmenopause age. And of course, it is related to estrogen deficiency and other physiological changes at the level of the hypothalamus and the pituitary glands. Okay, let us start with the vasomotor instability with hot flashes, which is the sensation of heat over the chest, neck, and the face, followed by sweating. It is the most common characteristic symptom, and its duration vary. It may happen in few seconds up to 30 minutes, may be associated with palpitation, headache, dizziness, and so on. The hot flashes is due to increased FSH-LH, increased dopamine, increased norepinephrine, and increase in prostaglandin at the level of the hypothalamo-pituitary axis. Okay? Okay. So, what about the nervous and psychological symptoms? There is irritability, depression, moody changes, lack of concentration, sleep disturbances. The GIT changes that may happen in postmenopause may be abdominal distension, constipation. The urinary changes include frequency of micturition, stress incontinence or urge incontinence, dysuria, more liability for urinary tract infection. The genital symptoms related to atrophic, as you see in this picture, atrophic vaginitis with burning sensation, dyspareunia, okay, or sometimes symptoms related to genital prolapse, because we said there is atrophy of the ligaments supporting the genital organs. So genital prolapse may happen with its symptoms like heaviness, pelvic pain, and so on. Other symptoms that may happen like itching, okay, hirsutism in the upper lip and the chin, loss of libido in some women, obesity, and increased body fat, especially in the abdominal region. What are the health hazards related to menopause that may happen? Osteoporosis is the most important one, and the cardiovascular system. So, osteoporosis characterized by loss of bone mass and microarchitectural deterioration of bone tissue. Actually, third of women at the age between 50 to 60 may have osteoporosis, and this is a very big incidence. So, any menopausal woman should take care about this. What are the risk factors that may precipitate it or encourage the osteoporosis to happen? The white race is high risk, smoking and the high caffeine and alcohol intake. Early menopause is a very important risk factors if menopause occur before the age of 40. Low calcium diet, sedentary life, and some drugs enhance osteoporosis like corticosteroid and heparin. So what is the effect of the osteoporosis? Osteoporosis may enhance fracture vertebra, fracture neck femur, and fracture at the distal radius, and this is important to know. Curvature of the spine, also it may cause decreased height. It is diagnosed by bone density scan, as in this picture. This is DEXA, dual energy X-ray absorptiometry. This is the machine, and this is the screen, and we measure the score. So as you see in the picture, this is the DEXA for bone density scan. And according to WHO criteria, locked to this table, we can define the normal, the osteopenia, the osteoporosis, the severe osteoporosis. If the total score between if the total score is -1 or greater, it is normal. If the loss of bone mass, what's called osteopenia, between 1 and 2.5, it is called osteopenia. This is the T-score, okay? Okay, so T-score -1 or greater is normal. T-score between 1 and 2.5 is osteopenia, which is milder degrees than osteoporosis. But if T-score is -2.5 and below, it is osteoporosis, and this is more severe. But if the score is -2.5 and below, plus fragility fracture, this is severe case of osteoporosis. Okay? Okay. This is the criteria according to DEXA and WHO criteria for classification. Okay. The second big problem is the cardiovascular disease like ischemic heart, atherosclerosis, hypertension, and stroke. Increased blood cholesterol, increased LDL, and decreased HDL. Diagnosis of the menopause with the initial assessment for the presenting complaint of the lady, any specific menopausal symptoms like hot flashes and so on. Gynecologic history, we will take the last menstrual period because we said cessation of menstruation should be to 12 months, okay, after the age of 45. So we should know the last menstrual period. Previous medical and family history is important in our diagnosis and for planning for treatment. We should know very well any medical and family history. Examination, we should know the height, weight, body mass index, should measure the blood pressure, examine the breast and the abdomen, and do local pelvic examination to exclude any organic lesions in the pelvis. Investigation, you may need to do serum FSH to diagnose menopause if the lady between 40 to 45 with menopausal symptoms, and you will find the FSH higher than 25. Okay? Mill international rate, of course. Okay? Or maybe higher, maybe reaching 40 or more. So, FSH test also should be done if the lady complaining of menopausal symptom and she is younger than 40 to diagnose premature menopause or premature ovarian failure. Okay? Sometimes I'm in need for to do serum TSH. Why? Because hypothyroidism may simulate the symptoms of menopause. So I should test for TSH for that reason. I may need pelvic ultrasound, especially in high-risk cases, and be careful to measure the endometrial thickness. It is supposed to be atrophied in postmenopausal age and to be less than 5 millimeters in thickness. Also to do screen for the pelvis for any organic lesion. Bone density is not a routine screening test, but in high-risk cases it is important, and in patients with certain complaint suggesting osteoporosis or high risk for osteoporosis. And we can use in this situation DEXA, as we said before. So what is the treatment? First, the non-hormonal treatment. Reassurance is very important. Education of postmenopausal women about the physiological nature of these symptoms, and it will be relieved with time, and this is physiological. Don't worry about that. Regular exercise and physical activity should be encouraged. A healthy diet, which include cereals, vegetables, fruits, and high fiber, low fat, and add calcium 1,200 milligram per day and vitamin D 1,000 international unit per day. Avoid or restrict the drinking of coffee, tea, and cola, and of course alcohol. It is said that Chinese herbal tea may reduce flushes due to ginseng, which is chemically and functionally similar to estrogen. So, what else? We may give antidepressant from the class of the drugs called selective serotonin reuptake inhibitors because it may decrease menopausal hot flashes. Gabapentin also reducing the hot flashes. Clonidine also improve the hot flashes. Medication to prevent or treat osteoporosis in high-risk cases like vitamin D, like calcium, and biphosphonate or alendronate drugs, which precipitate calcium, enhance the precipitation of calcium in bone, and enhancing the osteoplastic activity. Treatment of other medical problems associated with menopause, like hypertension, diabetes, osteoarthritis, obesity. What about the hormonal therapy? Hormonal therapy is an era in recent years, and many published articles about the hormonal therapy. The very big research done in 1996 and the 1997, the Women Health Initiative study in USA and 1 million study in UK give many data about the hormonal therapy. Also other studies later on, and also Cochrane Library review during about the 2016 also gave us many information about the hormonal replacement therapy. We should know first that hormone replacement therapy doesn't suit everyone. It is not suitable for every woman. Each woman needs to be aware of the benefits and potential risks of hormone replacement therapy. Currently, HRT is recommended to be used to treat symptoms of menopause, but only on a limited basis, as mentioned by the American College of Obstetricians and Gynecologists. Okay, what is the indication for use in case of hormone replacement therapy? First, and very important, the cases of premature menopause, those who became menopause before the age of 40, because they are very liable for osteoporosis and other cardiovascular problems. Okay, so this is the first category. Then, patient with severe menopausal symptoms in whom the risk-benefit ratio is favorable in fully informed woman. After you tell her about all risks of hormone replacement therapy. This is very important. For those women under 60 years also who are at risk of an osteoporotic fracture in whom non-estrogen treatment are unsuitable. Okay, estrogen therapy, the most effective treatment option for relieving of menopausal hot flashes. Depending on personal and family medical history, estrogen may be recommended in lowest dose and the shortest time frame needed to provide symptom relief. Okay, so I'll try to give estrogen, but for the shortest time and and with smallest dose. This is important to avoid the complications. Of course, estrogen helps to prevent bone loss. If women still have uterus, you add progestin with estrogen to antagonize its action on the endometrium and to avoid the development of endometrial hyperplasia and endometrial carcinoma. Okay? Long-term use of hormonal therapy may have some cardiovascular and breast cancer risk, as we'll see. Okay, regimens of treatment may be continuous unopposed estrogen or continuous progestin or continuous estrogen and progestin or cyclic estrogen and progestin. And if I have an example for a low-dose therapy, this is the conjugated estrogen 0.3 milligram plus 1.5 milligram medroxyprogesterone acetate. This is an example of a small dose. Of course, hormone replacement therapy could be an oral or vaginal or intramuscular injection or skin patches. So I have different types of hormone replacement therapy. Vaginal estrogen, as in this picture, this is suppository, okay, and the creams and tablets, okay, relieve vaginal dryness and improve genitourinary symptoms. This is very important to be known. In the form of cream or tablet or ring, and will improve the dryness of the vagina and urinary symptoms and improve dyspareunia if present. So what is the benefits and risks, the pros and the cons? Very important to be known. What is the benefits? The hormone replacement therapy relieve hot flashes, yes. Improve vaginal dryness, yes. Reduce the risk of colon cancer, improve the urogenital symptoms, protect against bone loss, and improve mood changes. Okay? There is improvement in mood changes also with HRT. Avoid the risks, although sometimes it is mild risk, but it is important, and you should know that the risks increase with advancement of the use of HRT, and it is said from studies that beyond the 5 years the risks are more. Okay, so try to stop treatment before 5 years. Okay, breast cancer, deep venous thrombosis, heart attack, gallbladder diseases, stroke, uterine lining growth, and uterine cancer are possible risks for HRT, although it is minimal risk, but it can happen and should be considered. And the risk increase, as we said, if the duration of use of HRT extend beyond 5 years. This is the different routes as you see in the picture: oral, transdermal, implants, vaginal cream, pessaries, and intrauterine system releasing levonorgestrel. We have what's called Mirena or levonorgestrel releasing IUD. Okay, and there is special releasing intrauterine system for postmenopausal lady with a smaller size. As you see in the picture, this one is smaller than this one. This is for postmenopausal lady, and they release 10 microgram per 24 hour, while the bigger one release 20 microgram per 24 hour levonorgestrel. This is an example for some oral estrogen products. As you see, different types of estrogen and doses. As you see here, for example, the Primarine, I have many doses: 0.3, 0.4, 0.6, 25, 0.9, and 1.25 milligram, which is the largest dose of Primarine, which is conjugated estrogen. Okay, so all these are examples of estrogen. Estrogen preparation and doses also. There is estradiol patches with different doses, estrogen progestin patches. Here we have estrogen plus progesterone, and there is topical gel, only estradiol, and there is topical spray, only estradiol, and there is intravaginal ring releasing estradiol over 3 months. Okay, so this is different preparation and doses also. Also in this table there is preparations which can be given intramuscular or vaginal. Intramuscular, like depo-estradiol 5 milligram per milli, and vaginal estrogen preparation like vaginal ring, vaginal tablet, vaginal cream, Okay? Again, there is Primarine vaginal cream. We said Primarine oral tablet, and we have Primarine vaginal cream, which is conjugated equinestrogen. Okay? Okay. So I have different forms and different doses and different preparation, as you see. What is the duration? This is a very important question. What is the duration for using HRT? The standard has been 5 years or less because risks increase with advancement of treatment beyond 5 years. And of course, it is important to mention that not to use HRT beyond the age of 60 because the risks increase. Okay? Okay. What is the follow-up? We will do follow-up for a postmenopausal lady taking HRT every 3 to 6 months interval accordingly and according to the rest. Okay? In the early years following menopause, then every 12 months later. Okay? At each visit, you should take history, complete history taking, any symptoms develop, any complaint. Then you do general and abdominal and the local examination. You measure the blood pressure. You do breast, abdominal, and the abdominal examination. You will search for any breast mass, which is very important. Any abdominal mass also is very important, or pelvic mass. You may do transvaginal sonography for measuring the endometrial thickness and for any pelvic organ lesions. If there is abnormal bleeding, you may need endometrial sampling to exclude the occurrence of endometrial hyperplasia or endometrial carcinoma. Also, during follow-up, you are in need to do mammography, routine mammogram, and breast examination are recommended in patient taking HRT. In Women Health Initiative study, the risk of breast cancer with combined estrogen progestin therapy didn't increase until the 4th year. So this risk increased with the 4th year or after the 4th year. However, abnormal mammogram were more common with both estrogen and progesterone treatment. Okay? So abnormal mammogram occur with estrogen and progesterone therapy, combination of both, more common. What else during follow-up? I said I will take history, I'll do physical examination, I'll do transvaginal ultrasound, and I'll do mammogram, and I'll do endometrial monitoring. Endometrial monitoring for vaginal bleeding, because vaginal bleeding in women receiving hormone therapy may require an evaluation of the endometrium to rule out hyperplasia. Okay? Okay. In case of postmenopausal women with irregular bleeding, before you start your therapy, an endometrial biopsy is important to rule out a typical endometrial hyperplasia or a carcinoma. Okay? Vaginal bleeding can be followed for the first 6 months after continuous combined therapy. And the endometrial biopsy is necessary if the bleeding persists beyond this point. What is meant by that? If I give continuous estrogen and progesterone therapy as a hormone replacement therapy, it is possible to some spotting to happen during the first 6 months. But if it is extended beyond the 6 months, you should do endometrial biopsy to exclude endometrial hyperplasia and endometrial carcinoma or any other cause. Okay? Okay. Also, the use of transvaginal ultrasound and alone or with Doppler for endometrial monitoring may be beneficial also for evaluation of the endometrium. Another lines of treatment that can be given to postmenopausal lady is tipolone and raloxifene. What is tipolone? This is the selective tissue estrogenic activity regulator drug. Okay, it acts like estrogen in certain area like food. Okay, so it is used for prevention and the treatment of osteoporosis. Okay, also raloxifene act on the bone via estrogen receptor and increase bone mass due to resorption inhibition. So both tipolone and raloxifene increase the bone mass due to resorption inhibition, so inhibiting the action or the activity of the osteoclast and encouraging the osteoblast. Okay, so improving the bone mass. This is an example for tipolone, and this is for example for raloxifene. Okay, tipolone is given in a dose 1.25 milligram per day, and the raloxifene is given in a dose of 60 milligram per day. Okay, okay. But this is not the end of the story, because I have certain important side effects you should know about tipolone. First, you should know that tipolone is considered a group of drugs related to synthetic steroid, has a weak estrogenic, progestogenic, and androgenic activity. And one of its advantages, other than the osteoporosis and the prevention of bone resorption, it improved the hot flashes. It improved the vaginal atrophy and the urogenital symptoms. So improve the vaginal dryness and improve and manage dyspareunia, and has positive effect on mood and sexual function. All this very nice. Yes, it is very nice. But what is the problem with tipolone? And you should know about it. In 2016, Cochrane review has been published on the short-term and long-term effects of tipolone, including adverse effects. So, what are these adverse effects? Unscheduled vaginal bleeding, increased risk of breast cancer in women with history of breast cancer, increased risk of cerebrovascular events, strokes, and the cardiovascular events, ischemia, and the cardiac attack, and increased risk of endometrial cancer. So, all these should be considered. Yes, tipolone has advantages in relieving symptoms of menopause, but have also hazards, which is very risky, as endometrial cancer, breast cancer, cardiovascular problem, strokes. So you should know about it. What about raloxifene? Raloxifene, as we mentioned before, increase specifically the spine and the hip bone mass density. The spine and the hip bone mass density. But one of its disadvantages, it doesn't improve menopausal symptoms. In fact, it makes it more worse. So hot flashes will increase with raloxifene, not improve, will increase. And also leg cramps and swelling of the legs may happen. So this is side effects or disadvantage of raloxifene, as you see. What about another group for treatment of menopausal symptoms called bioidentical hormones, which is derived from soya beans and plant extracts and are modified to structurally identical to endogenous hormones. But what is the opinion of American College of Obstetricians and Gynecologists and the Endocrine Society in 2016 about the bioidentical hormones? They are advising against the use of them. Why? Let us see. Before we see, have a look to this picture with this is different forms of bioidentical hormones, as you see here. Then go to the American College of Obstetrician and the Gynecologist. Why they advise against the use of bioidentical hormones? For three main important reasons. First one, they said we have already approved estrogen and progestin formulation in all countries for HRT. So there is no rationale for use of non-approved products, and this is logic. Second, there are no randomized clinical trial demonstrating their efficacy or safety, okay, for treating menopausal symptoms. So why I use it? If there is no randomized trials demonstrating the safety and the efficacy of these bioidentical hormones or drugs, okay? This is the second item. The third item, they said the content, the dose, the quality, and the sterility of these products are not subject to regulatory oversight. When tested, potencies and the patterns of absorption of compound estrogen have been highly variable. So they have query and suspicious about the content and the dose and the quality and the sterility of these products. This is the third important item. Lastly, what about the use of testosterone therapy? Use of testosterone therapy have many preparations, maybe injection, maybe transdermal patch, maybe oral tablet, okay? So different formulation present of testosterone. But it is not recommended for routine use during menopause. And the level of endogenous androgen don't predict sexual function for women. So you cannot predict the sexual function for women according to the level of endogenous androgen. But what's surprising you that in some studies they found that when serum androgen increased to the upper limit or above it, in a postmenopausal woman, there is improved in female sexual function in selected populations. Okay? So, what about the approval of testosterone use in different countries? Some European countries approved its use, however, in United States, it is not approved for use. This is the last slide. Lastly, my advice to all postmenopausal ladies, try to reduce obesity, try to avoid obesity, to be like this lady, pear shaped, and not like this lady, apple shaped, and thank you.